Okay, we're ready to start again. My name is Christian Thoborg, and I'm the chair of this session. We're gonna continue with shoulder problems, and today we have the honor of having Dr. Chris Littlewood, who is a research fellow from Sheffield University, and he has a strong clinical background, and his work has mainly been in shoulder disorders and lumbar spine disorders. He has done quite a large number of research within this area, especially in relation to tendinopathy and also rotator cuff injury and in relation to rehabilitation of these kind of injuries. He has more than 40 publications in the area and has also been co-authoring of a book called Understanding Physiotherapy Research. So it's a real pleasure to have you here, Chris, and I'm looking forward to this talk because it's really nicely connected to the first talk we had this morning. So thank you very much for coming.
Great. Thank you, Christian. Can I just begin by thanking the organising committee for having me. It's great to have the opportunity to share my perspective, but I also want to extend my congratulations to the organising committee. It takes so much work to put on what promises to be such an outstanding conference, so congratulations to all of you that were involved. So, my perspective on rotator cuff tendinopathy. I think the outcome might be a little bit different to Andrew's before, but hopefully I'll take you on a journey and share where my thinking is now and where it might go in the future. But just to begin, I want to really re-emphasize the point that Andrew made. In the UK alone, a small country like the UK, over 500,000 adults are consulting their general practitioner with a new episode of shoulder pain each year. That's 500,000 people with a new episode. That doesn't take into account people with ongoing problems. In older populations, we're seeing up to 1 in 4 people complaining of shoulder pain at any one time. But for me, the real data to focus on is below. So 70% of people with a new episode of shoulder pain are not recovered by 6 weeks. I guess most people wouldn't be too worried about that. But then for me, the story begins to change. So by 6 months, 50%, 1 out of 2 people who complained of a new episode have persisting problems. And by 1 year, 40% still not recovered. And for me, that's a real stimulus. We need to look at this problem differently in the context of it being a long-term condition which has direct implications for the interventions that we offer. Now, shoulder pain, we all know, is the 3rd most common reason for muskuloskeletal consultation after back and neck pain. And you'll see most people in this area describe disorders of the rotator cuff as the most common cause of that pain. But I just want to be really clear to you because I get confused on a daily basis. It seems to me that we use the same terms to describe different conditions and different terms to describe the same condition. So in relation to the rotator cuff, you will have come across things like subacromial impingement syndrome, subacromial pain syndrome. When I first started off as a physio, anybody who could move their arm, but it hurt when they did and when they lifted, they all had the label of supraspinatus tendinitis. For those of you that have been around long enough, we stopped saying that in the 90s. We started telling everyone they had tendinosis. Then we became unsure again, so we said tendinopathy. And now we go back to the start. Other labels such as bursitis, etc. But when I talk about people who say, Chris, my shoulder hurts. I can still move my arm, but it hurts me to do so. If I lift something or lie on that side, that reproduces my pain. I label those people as having rotator cuff tendinopathy. And I've got reasons for that. I think it's credible. It reflects the load-induced nature of this problem. I think possibly most importantly, it's acceptable. It's a credible basis upon which you can begin to explain the problem and prescribe an appropriate therapeutic exercise program to your patients. And I'll come on to that later. And equally as important, it's not harmful. And I regard the term subacromial impingement syndrome as a harmful term and something that should be avoided and stopped. So rotator cuff tendinopathy. My approach to classification is as follows. I exclude a movement-related problem at the neck. And to do that, I move it repeatedly in different directions. And I'll go through the practicalities of this in a second. I think I prefer a repeated movement assessment because my starting preference is to keep the control with the patient. I look to exclude people with movement restriction at the shoulder because I think the interventions that benefit people with movement restriction might be different to those that benefit people without restriction. And to do that, I look at lateral rotation. And I look to confirm the problem by reproducing their pain with resisted testing. That's what I mean when I say rotator cuff tendinopathy. I'm quite sure that some of you will contest that and have different terms that you use. All I do is ask you to reflect on why you use those terms and where the evidence is taking us. That might not be the term that I use forever, but at the moment, for me, that's the most acceptable and credible terminology for this group of people. Okay, so typically, if people come to see me and they say, Chris, my neck or shoulder hurts, if they grab around their trapezius, I would say that more often than not, that is not a shoulder or a primary shoulder-related problem. When people grab their upper arm and say, Chris, my shoulder hurts, that's one sign. Rather than do any specific testing, the first thing I ask the patients to do, once I've got their consent and determined what their expectations are, I say, is there something that you can do that reproduces your shoulder pain? So I look for some kind of functional test. And for the majority of people, a simple upper limb movement will do that. And that's my baseline test. I then ask them to repeatedly move their neck, so retract and repeat, reassess the baseline. So you've moved your neck now. As you move your arm, does it feel any different? And we're looking for substantial changes. If it doesn't, we might move on to retraction, extension of the neck. And again, after a procedure of maybe 8 to 10 repetitions, I ask the patient to do the functional test again. If the sagittal plane movements have no effect, I look for side flexion one way, side flexion another way. If there's absolutely no movement, no change in presentation at the shoulder, that's where my cervical spine assessment will end on day 1. If there's some uncertainty, I might look to overpress into directions or explore rotation. So once I've excluded the neck, according to my process, I look to see whether they have at least 50% of lateral rotation. If they do, for me, that excludes people with a primary problem of shoulder limitation. I then look to do repeated tests, resisted abduction, lateral rotation, possibly flexion, not necessarily just at arm by side, but for some people, particularly the more able, you might need to look at loading in mid-range or functionally in a weight-bearing task, for example. That's up to you as a professional clinician to decide what might be the most appropriate resisted test to use. And that's my assessment on day 1. If I can exclude the spine, exclude restriction, and confirm with a resisted test, my provisional classification is that of rotator cuff tendinopathy. And of course, whenever I do a presentation like this or talk to people, people rather consistently come back and say it's too simple. What about this? What about that? So I thought in the presence of such an audience, I should justify that approach before I get into the specifics of therapeutic exercise. Because for me, if you're going to use a test, if you're going to make a diagnosis or a classification, those tests should have some degree of reliability. You should be able to agree with yourself if you repeat the test and agree with another clinician. Importantly, I think a test, a diagnosis, or a classification system should inform your management planning if it's going to be useful. Or if it can't inform management planning, it should have at least some bearing on prognosis. And when we look more closely at some of the tests and the scans we use, they don't fulfill these criteria. So with a group of colleagues a few years ago now, we did a systematic review looking at what people regard as these special orthopedic tests. The Hawkins-Kennedy, the empty can, the near sign, the Jobs, etc., etc. And we concluded from this systematic review that there is no consistent evidence that any examination procedure used in shoulder assessments has acceptable levels of reliability. So that means if I do a test today on a patient, and that patient doesn't change, and I repeat the test, I might well disagree with myself. If I do a test, and as often happens, you're confused, you go and see a senior colleague, they repeat that test, they get a different answer. That's not because of your incompetence, that's because that's a product of the test that we're using. They have poor levels of reliability. And the importance of this is that we often justify treatment on test, retest. And if tests have poor levels of reliability, how can we be confident that the change we see is real and not just our perception? Jeremy Lewis has been talking about this for a long time now, that special orthopedic tests, maybe they're sensitive, but not specific. So essentially, they hurt people with shoulder pain, but they also hurt people without shoulder pain. And it's completely unrealistic to think that these special tests selectively tension any of the tissues in our shoulder. For those of you that have been fortunate enough to train with cadavers, not fellow students, cadavers themselves, then you'll notice that the functional unit, the rotator cuff, the shoulder, is a functional unit. And the idea that a specific test can locate one of those structures is just not realistic. And essentially, the truth is, if your patient comes to you and says, I've got pain in my shoulder, and then you do a whole series of these tests, and legitimately, at the end of those tests, they say to you, what can you now tell me about my shoulder pain? What have those tests told you? All that you can tell them is that their shoulder hurts. But you'll have spent 15 minutes, 20 minutes doing that, and they told you that right at the start of the consultation. Now, with regard to imaging, we're seeing a real proliferation of the use, particularly of diagnostic ultrasound within MSK. And this is quite an old study now, but essentially Frost and colleagues took two groups of people, one with a diagnosis of subacromial impingement syndrome, one without that diagnosis. And what they wanted to know was, can we differentiate the symptomatic group from the asymptomatic group based upon pathology? And no surprises, they couldn't. They could not differentiate those with shoulder pain from those without shoulder pain based upon the findings of the scan. What we also see from a wide range of studies now are high rates of asymptomatic cuff tears in the general population. So one question that really confuses me on a daily basis is, a patient comes to me and says, my shoulder hurts, a scan has shown I've got a tear in the rotator cuff. How can we be sure that that tear in the rotator cuff explains their pain in the prevalence, in the presence of such high prevalence rates of asymptomatic tears? I don't think we can. Our reasoning is flawed. I undertook a systematic review asking the question, well, can we get a little bit smarter? Can we predict who might respond to physiotherapy? So we took a whole bunch of studies and we looked to review prognostic factors. And what we found is that the biomedical diagnosis, so for example, bursal thickening that you see reported on lots of scans, calcification, the presence of degeneration in the tendon, partial or full thickness tears are not associated with clinical outcome. So these people can have a grotty looking shoulder and still get better. When I started my PhD journey, I had this notion in my mind, and I don't mind admitting this now, but I had this idea that people had tendon-related pain because their tendon was worn, it was degenerated, that we could explain pain from a structural pathology perspective. And my perspective was that we need to apply heavy loading exercises to change that structure. And naively, I looked to explore that hypothesis by doing a systematic review with a colleague, Ben Drew. So we took a group of studies that recruited people with tendon pain. So that could be the Achilles, that could be the patella, it could be the common extensor tendon, the rotator cuff. But we took studies that recruited patients with tendon problems, measured clinical status at baseline, but also took some kind of imaging picture, typically ultrasound or MRI. These studies then applied a therapeutic exercise program. They repeated the measurement of patient outcomes at the end, and they also repeated the scan. And what they found quite consistently across studies is that patients responded favorably to the therapeutic exercise regimes, but the scan did not change. So the scans that we employ at the moment don't adequately explain the response that we see in our patients. Interestingly, I guess you'll hear more about this study later, so I won't say too much. But in response to imaging, one other angle that people suggest is that by using imaging, it can improve treatment accuracy using injections in the shoulder. And the hypothesis is that if we improve accuracy, then clinical outcomes should improve. And this study, I won't say much more, but has blown that hypothesis out of the water. Okay. So these arguments have been around for a while, and some authors have moved from a pathoanatomic diagnosis, so trying to identify a structure at fault, to more of a rehabilitation classification. If we can't use biomedical diagnosis to plan our treatment, what can we use? And some of these procedures, so for example, the shoulder symptom modification procedure, Mackenzie's mechanical diagnosis and therapy, the recently published STAR shoulder, attempt to, for example, identify impairments and see whether those impairments respond within a session. So just because someone's got a cuff tear, for example, if we repeatedly laterally rotate their arm and their pain reduces and their movement improves, that would be the therapeutic treatment strategy. But in relation to rehabilitation classification systems, they have limited evaluation at the moment in terms of reliability. So can clinicians agree on the classification? We don't know fully yet whether actually matching treatment according to the rehabilitation classification improves outcomes, or whether that initial classification can help us predict prognosis. So even though there's some potential promise there, this is an area that needs much more evaluation before we can say that's the solution. But interestingly, Garrison and colleagues took a group of people with subacromial impingement syndrome, and I'm using that term because they did. It's the wrong term in my opinion, but I'm using that term because they did. But they took a group of people with this kind of shoulder pain and applied modification procedures, movements within the session, and they categorized people as either having responded to the treatment within the session or not. And they looked to see whether that initial response predicted outcome. And in fact, from a functional perspective, whether people responded within session did not have a bearing on functional outcome. There was a weak to moderate association between whether someone felt better in the first session compared to how they felt at the end of the session. So there's some real uncertainty in this area. And it's because of that uncertainty that I've adopted the simple approach that I have. Hopefully that will adapt with time, but hopefully what you're seeing there is a simple data-driven approach. So we'll move on to management. It was 5 years ago now, and time really flies when you're having fun, but 5 years ago I surveyed physiotherapists in the UK, and I asked them, what do you do with this group of people? How do you manage them? And it's a survey that we're just repeating again to see whether practice has changed. But the question was, how do you manage these people with rotator cuff disorders? And we got a whole bunch of responses, a wide range of responses. And based upon the responses that the UK-based physiotherapists gave me, I undertook a review of systematic reviews, seeing, well, where does the evidence lie in relation to the most commonly prescribed conservative interventions? And to summarize that review of systematic reviews, exercise consistently seems to be the most promising intervention. Maybe it's because it's the most studied, but exercise seems to be something that we need to think about more carefully. Multimodal physiotherapy, so that might be, for example, physiotherapy plus injection, physiotherapy plus manual therapy, more than one approach within physiotherapy. So for example, as I've mentioned, so multimodal physiotherapy or surgery consistently confer no additional benefit over exercise alone. And that's interesting, I think, because we've seen, or we've consistently thought of surgery as the top of the hierarchy, the definitive treatment for this condition. And in fact, the evidence paints quite a different picture. And as well, multimodal physiotherapy confirms superior outcomes over no treatment or placebo. So it's better to do something than nothing, okay? But I guess most of us in this room will realize that exercise is quite a generic term. It's not a catch-all term, even though when you look at some of the reports of randomized trials, we don't get the detail of the exercise programs that as clinicians we need if we're going to effectively implement these strategies into care. So I undertook a further systematic review looking to see whether I could characterize what is an effective exercise program. What are the key characteristics that make an exercise program effective? And this review has been published in the International Journal of Rehabilitation Research. And this is what we found. So it doesn't matter whether you're a newly qualified physio or you've been going for 20 plus years. You can still confer or help your patients to achieve good clinical outcomes. Experience doesn't seem to be the key factor. Now, the next point is really important. Patients of varying age, duration of symptoms, and severity of pain and disability can achieve significant outcomes. So just because someone is old, however you choose to define that, just because someone has very high levels of pain and disability at the start, does not mean that we cannot help them with a therapeutic exercise program. I think we have this notion that we can predict who will respond. Maybe we're just misinforming ourselves. So this is important. A whole wide range of people can respond to therapeutic exercise programs. Maybe, though, those with a longer duration of symptoms or higher levels of pain and disability at the start just need longer to respond to our care. And that's, I think, an important point. Whether you choose to ask patients to exercise at home or whether your context is to bring them into the clinic doesn't seem to matter. Comparable outcomes can be achieved between both of them. But I'd really like to sensitize you to this point. Pain production or pain avoidance during exercise does not appear to matter. And I came to that conclusion because there's a whole bunch of studies that reported good clinical outcomes when the reasoning for the exercise was based upon a therapist's judgment of movement, for example, or simply on symptom provocation. So the idea that we need to avoid pain with these patients just doesn't hold true. And I guess this goes back to one of the questions before, this idea that we need, as physiotherapists, a window of opportunity provided by a corticosteroid injection. We don't. We can achieve good clinical outcomes even when the patient comes to us with moderate to severe levels of pain. I'll go on to describe later because my preference is still to prescribe exercise based on symptom response, so based upon pain. And I think there are important reasons with regard to treatment progression and also self-monitoring. So a patient knows when to progress their exercise if you're using pain as the response. But critically, remember what I said about this problem earlier. We should be considering this in the context of other long-term conditions. People don't tend to respond to management programs for rotator cuff tendinopathy quickly. It takes time. And one thing that we need to be facilitating is self-monitoring. Where are you starting? Where are you going to? What is the journey between? And it's self-monitoring that is one of the keystones of self-management and something we should all be aware of. But again, I'll come on to that when I talk about a later study. So inclusion of some level of resistance seems to matter. So again, I'll go back to when I first qualified as a physiotherapist. Patients used to come into the treatment room. We used to rub the heck out of the front of their shoulder until they gave in or our fingers went numb. We'd then apply therapeutic ultrasound, and they'd be asked to go away and do some kind of pendular exercises. The studies that have looked at that kind of exercise without resistance don't seem to report good outcomes. There needs to be some level of load applied to this exercise. How much load, we're not sure. Also, the people that tend to do higher numbers of repetitions and sets seem to do better. So adherence seems to be key. Again, we're not sure what that upper limit is, but patients need to be encouraged to do their exercise frequently. And you need to sign patients up to be thinking about this as a minimum 12-week program. And I hear this all the time, patients won't find that acceptable. They absolutely do. I think it's us as physiotherapists and clinicians that don't find it acceptable. We want to find the quick fix, the silver bullet. And this is not the truth of this longer-term condition. As long as you're very clear with most patients, with all patients, that this will take a minimum of 12 weeks, they're fine. Set the prognosis from the start. One patient said to me, "Chris, why on earth would I expect this to get better quickly? I've had it for a long time." Okay, that's important, but you need to set the prognostic prediction at the outset. If patients get better in 3 weeks, great, it's win-win. If they take longer, then we need to work with that. But you need to be framing this around a minimum of a 12-week commitment. Okay, so in relation to the review, one question we haven't answered yet is, well, what about the type of exercise? And interestingly, the studies reported that patients can achieve good clinical outcomes with a whole range of different exercises. What appears to be the key feature at the moment is getting people to do that exercise regularly. But one type of exercise that features quite frequently are these scapular stabilization exercises, what some people refer to as motor control exercises. So you would expect that the case for inclusion in therapeutic exercise programs is strong. But I guess most of us now know scapular dyskinesis is present in those with and without shoulder pain syndromes. And for me, the next study was really important. They reported that the scapulae of dominant shoulders shows greater retraction and upward rotation at all points during elevation of the arm. Now, why is that important? It's important because we tend to assess dyskinesis with reference to the asymptomatic side. But what this study suggests is that we're asymmetrical beings to begin with. So if we try and assess one side to the other, we're different to start with. Okay, so reasoning based upon that is potentially flawed. Liz Ratcliffe published a review in the British Journal of Sports Medicine in 2014, asking the question, is there a relationship between this shoulder pain syndrome and scapular orientation? And some interesting conclusions, I think, that we should all take note of. Currently, there is insufficient evidence to support a clinical belief that the scapula adopts a common and consistent posture in this pain syndrome. So that fits with some of the previous evidence that I mentioned. But it also raises the possibility that deviation from a normal scapular position may not be contributory to this impingement syndrome, but just part of normal variation. Maybe one thing we need to consider is that as musculoskeletal clinicians, we're often taught from the perspective of a textbook and an ideal neutral posture. Well, maybe that isn't the case in real life. Like some other approaches to assessment, the levels of reliability for scapular dyskinesis are poor, whether you choose to use low-tech or high-tech means. And sometimes we even struggle to agree whether dyskinesis is present or absent, never mind the finer detail. But interestingly, and this also reflects the low back pain experience, and I'm a real believer that we should learn from history and not repeat the same mistakes. But as with low back pain, what we're seeing in the shoulder is that there's no clear advantage in terms of clinical effectiveness of specific scapular stabilization exercise programs versus just general exercise programs. And two studies to quote, Philip, who's sat in the audience, we'll look forward to listening to him later in the Congress, and Camargo, a more recent study. Essentially, they took two groups of people and a group of people and randomly allocated them. They took measures of clinical status at baseline and also measures of dyskinesis. They applied a therapeutic exercise program, and with Camargo, some manual therapy also. And just like the previous systematic review that I talked to you about, patients responded to the therapeutic exercise program, but the measures of dyskinesis did not change. And I'd just like to draw your attention to the conclusion from Camargo et al. In 2015. The noted improvements in pain and function are not likely explained by changes in scapular kinematics. Okay. So on this basis, I wanted to conduct a pragmatic study in relation to the rotator cuff. And this is the protocol, the basis of what we did, which is published in BMC musculoskeletal disorders, and I want to go on to describe some aspects of this research. Going back to my point earlier that many clinical trials report less than a paragraph of their exercise intervention. For those of you that are interested in the exercise intervention that I'm about to describe to you, it's described in full in a published paper in the Physiotherapy Journal. If you don't have access to that, then you can access the paper freely through my webpage at the University of Sheffield. There's an open access link there, so you can get the detail if you wish, okay? But the full detail is in there. But briefly, in this study, we looked to compare a single self-managed exercise versus usual physiotherapy treatment. So usual physiotherapy was the physiotherapist prescribing whatever intervention they would usually prescribe, whether that be exercise, whether it be motor control exercise, whether they choose to strap their patients up, put some needles into patients, maybe use some manual therapy, injection. That was up to their discretion. So that was the comparator group. You do what you feel is necessary and usual. In the single exercise group, patients were prescribed just one exercise at a time. At any one time, they only took one exercise. They knew how to progress that exercise in terms of how to make it harder. So just for example, they might go from an isometric exercise at their side to mid-range abduction with a dumbbell or a tin of food, for example. So they knew how to make the exercise harder, but they knew how to make the exercise easier if their pain response was too much for them. What might happen over time is they might be prescribed one exercise, but as the clinical status changes, we would prescribe another exercise in relation to the status, but they would leave the last exercise behind. So it was only ever one exercise. And it was prescribed on the simple basis that the exercise should produce pain during movement and it should be no worse afterwards. That's as simple as it got. If the movement reproduced their pain and settled afterwards, then that was the direction that we prescribed the exercise. Now, what people often ask me at this stage is, well, how many out of 10 do you prescribe your exercise? When is too much? When is not enough? And I've got to admit, we took a very simple approach because I couldn't make sense of prescribing an exercise for 3 out of 10 that might mean something to one person and something to another. I couldn't make sense out of prescribing an exercise that was 5 out of 10 that might mean different things to different people. So it was really simple. And I'd be great to, when we're talking over the next few days of the Congress, to get any of your thoughts. But we simply said, if it was acceptable to the patient, it was acceptable to us. So can you deal with that? Is that okay? If it was yes, it was fine. If it wasn't, so for example, if a patient, they might return, for example, or they might say on the first day, the pain in bed's been too much, I've been getting out of bed, it's disturbing my sleep. That's a sign you need to regress. If pain was stopping during exercise, that's a sign they need to progress, make it harder for themselves. If we found, for example, that, again, just a starting point, that resisted abduction produced their pain, but then they said, no, that's hurting now. No, I can't deal with that. What we might do is look to lessen the load or typically change the direction from abduction to lateral rotation to flexion, as long as the exercise produced pain that was acceptable to them afterwards. And I think when I speak to people about this, it can be quite different to conceptualize. It's just because it's so simple, that's it, okay? Based on symptom response and one exercise. Now, people confuse what self-management means. People think you assess them and send them away. That's not a definition of self-management. Self-management is providing access to care when the patient needs, so they can get on and do things by themselves. So they could come back and see the physiotherapist if they wish to. And there was a whole range of responses. Some patients would say, is that it? That's what I need to do? I'll go away and do that. And they just have a phone number to contact them if they wanted to come back. Other people would come back on a regular basis. So we leave the follow-up to the discretion of the patient first and foremost, based upon their need, and the physiotherapist. But typically, patients were seen 3 or 4 times over a 3-month period. And in the main study, they were told very clearly this is a minimum of a 12-week period, 12-week commitment. Interestingly, what we found was physiotherapists have a fear avoidance of pain, and I'm increasingly thinking that physiotherapists and, well, no, maybe all clinicians actually. I guess I get more exposure to physios. But I'm starting to create the hypothesis that fear avoidance is more of an issue for physiotherapists than patients. And this became quite apparent within the study. But I was speaking to a group a couple of weeks ago, and they said, Chris, the actual intervention is very simple, but what is complex is the wraparound. And we spent a lot of time with the wraparound. And what do I mean by that? So the single exercise was prescribed within what I termed a self-managed framework. We spent time listening and talking to people and trying to help them have a constructive understanding of their problem. And I'll go on to talk about this towards the end of the talk, but essentially we described this problem as a deconditioned muscle and tissue that needs strengthening. We avoided reference to cuff tears, impingement, bone spurs, because of the potential harmful connotations. So I'll return to that point. We spent time with patients making sure they knew how to do the exercise that we'd agreed on. What we didn't do was give a list of printed exercises to them and say, go away, do these, see you next time. We didn't text instructions or send the exercises via email, which seems to be an increasing trend. We spent time encouraging the patient, showing them, the physiotherapist demonstrating, the patient repeating until they mastered that skill. Because you can think yourselves, when you're not confident about a task, whether that be an assignment, building a wall in the garden, whatever, more often than not, you'll put that task off. You'll do other things first. If you're a master builder or you got a first-class mark the time before, it's more likely that you'll engage with that next task. So we spent time making sure the patients knew exactly what they needed to do and they were comfortable with that. We spoke about the need to self-monitor. So we used something called the patient-specific functional scale. Very, very crude measure, but essentially it asks the patient to detail a functional task and it asks them to score on a scale of 0 to 10, how difficult is that today? And they monitored their progress over time, because you must have seen this in your own clinical practice. A patient comes back to you feeling down. I've made no progress, they tell you. You re-examine them, and for example, the shoulder that was stiff at 90 degrees before now moves almost to full range. The patient who could barely touch their knees before can now touch their toes. Patients get lost in this long journey. So giving them the capacity to show how they're changing over time is beneficial. Just like it might be beneficial to regularly weigh somebody in a weight loss program. We need to get better at facilitating self-monitoring because MSK conditions take time to respond. So they use the patient-specific functional scale. But critically for me, they also used an exercise diary, which was a monitor of their adherence to the exercise program. And it gave a message about how serious we were about the exercise and regularly adhering. And it was a simple tick box exercise diary. It's available on the paper that I mentioned earlier that describes this exercise intervention. But essentially, if the patient had done their exercise, they ticked it. If they did it again that day, it was 2 ticks. They drew a picture of themselves doing the exercise and listed down their specific instructions in their words. And that was a way of monitoring their adherence over time. And by asking them to complete a diary, it shifts the whole basis of the consultation from how's your pain to how have you adhered to what we've been asking you to do. Quite a different dynamic, quite interesting. And for some people, they found it quite useful to see, I've missed a day's exercise, I need to get back on it. Just like the person in the weight loss program, I've put a kilo back on, I need to get on it. It was a useful form of self-monitoring. The goal setting comes within the patient-specific functional scale, patient-specific functional scale. But importantly, we asked the question on the first day, how are you going to fit this exercise program into your daily routine? So this exercise program took 2 minutes twice per day. We started off with a notional value of 3 times 10, just because that's what everybody did at the time, but we were flexible around that. We might reduce the number of sets, reduce the number of repetitions. We might increase if the patients found it too hard. My own preference is to increase the load, maybe the weight, for example, or the direction or the position of the exercise, rather than getting them to do 40 or 50 or 60 repetitions. There are functional considerations around that, but that's tended to be the approach that we took. But we said, how are you going to fit this into your daily routine? And one chap, for example, pinned his exercise diary into his kitchen. Lovely chap who made his wife a cup of coffee every morning. While the kettle was boiling, he did the exercise, he made his tick, and he went back upstairs. Another lady took her hand weight to work with her. When she saw it on the desk, she did her exercises. Simple. And as I mentioned, the follow-up was proactive. It wasn't routine by any nature. It was, how long do you need to implement this exercise program? When do you think you need to come back? They were given this framework of an average person, which no one is, but typically we see people 3 or 4 times over a 3-month period. What would you like to do? If I was to do the study again, then what I might do, as much for the therapist's sake as the patient, then I might insert a shorter-term follow-up as a suggestion, maybe a telephone call just to check base, maybe after a week or so. But most patients seem to manage fine. On that basis, we did a pilot trial in private practice, so away from the UK National Health Service. We recruited to target very, very quickly, and most people were willing to be randomized, even in a private practice setting. We retained all 24 patients at 3 months, and the exercise adherence rates were excellent, which contradicts some of the other literature. I'll mention the SPARDI a little bit later, but the SPARDI is the Shoulder Pain and Disability Index. It's a very commonly used outcome measure. It's the most commonly used outcome measure in trials of conservative care. And essentially what we found is that both groups improved over that 3-month period. The self-managed group slightly more than the usual physiotherapy group, but again, because of the numbers, there's no degree of certainty around that. But both groups improved by what we'd regard as a clinically significant amount over the first 3 months. So what did that tell us? Well, it showed us that we could apply simple criteria and recruit people, and it also showed us that our intervention was feasible. And interestingly, and again, I'll show you more data, just have a think about the change over the first 3 months. People were prescribed a painful exercise regime, but still improved. Okay, and it was comparable to usual physiotherapy care. So that might be a stimulus, a challenge to some current existing thoughts about the need for a window of opportunity or relative rest in that early phase. Once we'd done the pilot study, again, the pilot trial is reported in the Physiotherapy Journal, and again, it's freely accessible through my webpage at the University of Sheffield. Similarly, the main study, the multi-center randomized trial, that was published in Clinical Rehabilitation, but again is open access on my webpage. But this was a multi-center trial using 3 centers, one in the north of England, one in the Midlands, and one in the south. And we recruited patients, 86 of them referred into physiotherapy. And we used this very simple classification system. So can you still move your arm? Can we exclude people with a stiff shoulder? Can we exclude people that we believe might need treatment directing at their neck first? And can we reproduce your pain by resisted testing? As I mentioned, patients were randomly allocated to this self-managed exercise intervention or usual physiotherapy treatment. And that was as described. And when I looked at the patient records, typically the physiotherapists in the UK were using a greater range of exercises, often including motor control exercises. They would often be less aggressive with their exercise prediction, frequently not using pain as a guide, rather a judgment about motor control. In some centres, there was a tendency towards manual therapy. In some, a tendency towards some electrotherapy, which again was an interesting finding, maybe more led by the ethos in the department rather than the evidence. But there was a mix of treatments that were offered in the usual physiotherapy arm. We followed people up 3 months after randomization, 6 months and 12 months. And this shoulder pain and disability index was the primary outcome. So this is valid and reliable for use in this population. And what we tend to crudely say is that if patients change by 10 points on this SPARDI, it would be regarded as a clinically significant change. So that's something that you as a clinician might recognize as a good thing, and the patient might say, my arm is feeling better. Okay, so we randomized 86 patients, 42 to the self group, 44 to the usual physiotherapy treatment group. But we lost patients over the 3 months. So in this context, we need to be cautious about how we interpret these results. We lost people. Reasons are not clear. But what was apparent was that we lost patients across both groups. Initially, when I entered this study, my concern was that the intervention, the self-managed intervention, wouldn't be acceptable to patients. From the qualitative work we did, that doesn't seem to be the case. But we lost patients across both groups. And interestingly, they seemed to be the younger patients who reported higher levels of pain and disability. So maybe these are people who perceive themselves as having more complex problems, and maybe the way that we're engaging with them isn't addressing those issues. And here's what we found. So both groups starting at quite high levels of pain and disability, according to the SPARDI, 49 at the start, and both groups improved by what would be regarded as a clinically significant amount over the 3 months. So mirroring what happened in the pilot study. We couldn't report any significant change between groups at any time point, but what is quite interesting, and tends to be atypical in trials of this nature, because most treatment is offered within the first 3 months, what we saw between 3 and 6 months in the self-study, within the self-managed arm, is that patients continued to improve by what would be regarded as a clinically significant amount. And this is something I'd really like to explore further in a bigger, wider study in the future. Okay, so that's exercise, but for me that's only one side of a very big story. You know, I mentioned earlier that we need to be thinking about credible and acceptable explanations for our patients. Why would a rational patient engage with a 12-week exercise program if they don't understand the reasons why? And I'm not sure we do a good job at this. And one reason is, when we ask the question, what is causing the pain of tendinopathy, as we heard quite eloquently from Andrew earlier, we just don't know. There's lots of uncertainty. So that makes our job hard. What we've seen is the development of pathology pain models, so by Craig Purdom, Jill Cook, for example, and that was adapted to the rotator cuff by Jeremy Lewis in 2010, that describe these 3 phases of reactive, disrepair, and degeneration. And when you look at the literature, the continuum model describes the change in pathology as according to the data. But as we've heard, and as we know, that the relationship between pathology and pain is far from straightforward. And for anyone that's interested, I had the opportunity to speak with Craig, Jill, and Ebony Rio, who's doing lots of good work in Australia via a British Journal of Sports Medicine podcast, which was almost 2.5 years ago now. But I asked some of the questions that I had to the 3 of them. So for any of you that are interested, that might be a useful 30 minutes of your life. Okay. So for those people that recognize the disconnect between pathology and pain, we've seen more exploration in relation to the biochemistry of pain and tendinopathy. And so some people are suggesting that, for example, it's the biochemical mediators, substance P as an example, that are driving the nociceptive input, either by stimulating the nociceptive afferents or reducing the threshold at which they fire. We heard a wide-ranging review from Andrew before about the range of the role of inflammation within tendon problems. But again, there's still lots of uncertainty. We just don't know. So we need to make some useful foundation upon which we can talk to our patients about the problems that they have. And for those of you that have an interest in this area, Ebony Rio and colleagues wrote a really extensive review a couple of years ago now, looking at these kind of factors in tendinopathy. And they concluded that there are many biochemical changes in tendinopathy, but none of which can fully explain tendon pain. And 2 years on, I think that conclusion still holds true. But then there are some really important thinkers in our world for me, And Lorimer Moseley is one of them, who consistently says, and I think this quote is attributed to him, but maybe didn't originate from him, but we know that nociception is neither sufficient nor necessary for a pain experience. It's more complicated than that. And as I was thinking, these previous pathology pain, these biochemical models, are not thinking about the person within the pain experience. And I constantly go back to a patient that I saw a while ago now, but he was a stimulus for this slide. But what is the likely output, the pain complaint of a patient who believes that their shoulder pain is being caused by tissues being compressed, being catching, being irritated by, for example, a bony spur, bony outgrowth? What is their likely presentation when you ask them to move? I would suggest an exaggerated and often fear-avoidant response. Why would someone move their arm above that level if they thought that pain was being caused by a bone spur piercing a bursa and a rotator cuff tendon? Any rational person would avoid that. That's why I think this subacromial impingement model, which Jeremy Lewis has critiqued and others have as well, should now be regarded as not useful, outdated, and should be made redundant. I don't think it's a helpful basis upon which to prescribe treatment. But my question is, as a physiotherapist, I understand the complexity of the pain, or I try to, and I know that there's potentially lots of things going on. But for now, what factors can I influence to help my patient? That's my question. And this is why I found the late Louis Gifford's mature organism model extremely helpful. It recognizes that nociception might be a part of some pain experiences. It recognizes the environmental role that can influence pain experiences. But what it suggests is that every input to the person, the nervous system, is scrutinized. Sense is made of that input. And if we're about to be caught by a lion, but our ankle is broken, we'll override and we'll run. Okay? For those of you, people like Lorimer Moseley are far more eloquent than me, and he does a lovely TED talk explaining this concept. But essentially, there's a process of scrutiny based upon past experiences, knowledge, beliefs, culture. So if your knowledge is that I've got a bone spur that's sticking down into my rotator cuff that's piercing tendon tissue every time I elevate my arm, it's highly unlikely that you'll engage with a therapeutic exercise program, or at least a useful exercise program, not one that promotes fear avoidance. So I think we need to take this idea of scrutiny by the person more seriously. Some people have shifted their interpretation of pain. I think most of us in the room have grown up with this idea that the amount of pain that someone experiences is directly correlated to the degree of injury. So if they complain of lots of pain, they must be hurting they must have a pretty serious injury. And we just know that's not the cause anymore. Pain is no longer regarded as an input to the central nervous system. In fact, it's regarded as a modulated output of the person. It's a response to a threat. So for example, that load has the potential to threaten me, do some damage, and need to take a different course of action. And frequently, it's based upon what that pain means. And for me, this model rationalizes the on-off nature of rotator cuff tendinopathy. They load, they threat, they remove the load, the threat goes away. The pain is on, the pain is off. Okay? So this is how I think and how I try to talk to patients about rotator cuff tendinopathy. The pain is in response to deconditioned tissue. It lacks fitness, it lacks strength. But for me, the capacity of a tissue is not just about the tissue itself and the biological features, it's about how they perceive that problem as well. And rehabilitation has to take into account both how they perceive that as well as progressive exercise programs that gradually increase tissue and person capacity. Okay, so if I can just conclude in relation to how I think about this problem at the moment, I think in terms of the special orthopedic tests that we use, I think they're limited, both the examination tests and the imaging. We need to get smarter. complex physiotherapy in terms of the range of interventions that you offer does not seem to add value in the way we prescribe them at the moment. So I guess my point of reflection for you all during the Congress and maybe returning to clinical practice, why not do the simple things well? So focus on the advice and the explanation of the problem to a level that the person understands. And that's context specific, it's individualized. That's important. That's a real art for an MSK clinician. Focus on exercise, progressive exercise, over a minimum of a 12-week period. But I would suggest that we try to focus on exercise that maximizes adherence, so an exercise or exercises that patients can do regularly, but that so they can also monitor their progress or lack of it over time. And please be clear to patients about prognosis. It's important. If they understand what's required at the start, they're more likely to engage in the longer term. Thank you for your time.
Thank you very much, Chris. Just like to start by commending you on your talk, and especially what I think is absolutely brilliant and what we all can learn from is your systematic approach to this problem. So doing the systematic reviews, doing the pilot trial, and then do the trial is something that I think we should all aim for. Now we go to questions from the floor, and I have one question before, but if you can just raise up your hand and then just present yourself. Yeah, there's one over there, so let's just start over there. Yeah, Torsten, I think it is.
Hi, Chris. Excellent talk. Thank you very much for that. Adam Meekins from the UK. Your high dropout rate that you had in your trial, could it be that the patients actually just got better and didn't need to come back?
Again, I think the notion that patients did get better, I don't think holds true. Patients don't seem to get better. You know, this is a long-term problem. I think there are other issues that we're not considering, even though we often reassure ourselves that patients don't return in certain contexts because they're better. I don't think so. And the trend that we saw from, the early trend from non-responders was no different to responders. I just think, for whatever reason, whether they didn't think the intervention was appropriate for them, or whether they found another provider, for example, maybe some got better, but I don't think that explains the dropout in this context.
Can you hear me? Yeah. Thank you very much for a nice presentation. My name is Birgit Juhl Christensen. I'm Associate Professor at the University of Southern Denmark. I was a bit challenged by the thing you said that ultrasound is not correlated with functional outcome in rotator cuff tendinopathy. I think we have many black boxes here, as you also mentioned later in your presentation. For example, do we know the reliability of the ultrasound measurements of, for example, fibrillar disruption, vascularity, neurovascularity? And we actually don't really know about the precise diagnostic criteria for rotator cuff tendinopathy. Third thing is that the evidence for treatment is also very weak. Is it high load? Is it low load? And actually also as the fourth part, very seldom is the effect of an intervention in rotator cuff tendinopathy measured by ultrasound measurements. Actually, a recent study on Achilles tendinopathy.
Can we get to the question, please?
Yeah, I just was challenged by this ultrasound remark of you.
Yeah, I mean, sure. I made this comment on Twitter this morning. Current conclusions are based upon current methods, and maybe some of the uncertainties for the reasons, reliability, for example, people not doing this very well. Or maybe the alternative conclusion is that we're just going down a dead avenue and that this won't provide the answers that we think it will. I'll be quite surprised if we find all the answers to the pain of our patients in a reductionist scan. But maybe if the methods improve, we might find new insights, and there's certainly research around there. But I think the messages that I offered this morning are based upon the data and current methods.
Yes,
Okay. Is there any more questions?
Yes, please.
Okay, I'll take one in between, and then you can go, and then we'll end this session. Okay, so Chris, you showed that it's here. You showed that there was 30% that sort of didn't. Sorry. So you had this 30% dropout, or you couldn't measure the effect on 30%. So usually that's a little bit of a nightmare in an RCT like this. How did you handle this in the analysis?
Yeah, so within the analysis, we used two further methods. One was what we call the last observation carried forward. So we assumed that the last time they reported pain, that it hadn't changed. And we also used a process called multiple imputation that looks at the average of the other responders and inputs an average outcome point for that patient. It didn't change the conclusions, didn't narrow the confidence interval, which is why we've got to show some caution when we look at the results. But I think the trend is interesting and something that we really need to explore further. We're going down quite a high-tech, expensive route, and I think maybe we're missing some potential opportunities in the simple things done well. So, for example, the appropriate dosage of a therapeutic exercise program. We don't know that information, but instead we're funding studies that have high-tech, expensive interventions, and I think we're missing a trick.
And we'll get that last question, and then we end the session.
Yes, yeah. David Christiansen, I'm a physiotherapist. First of all, thank you for a nice talk, Chris, and very brilliant work you've done. I will also go back to the dropout, because you'll probably be hassled by that by others also. But could that be a matter of compliance, that your patients did actually not adhere to your exercise program and dropped out because they had pain?
It could be for a whole range of reasons, as I mentioned, but the dropout was comparable between the two groups. So
there was not a larger dropout in...
Not from a statistical point of view.
65% in your self-treatment group?
Yeah, but not statistically significant between the two. And what we found, maybe, I mean, this is an important point, maybe for some groups of patients that the self-managed exercise intervention isn't acceptable, just like for some patients surgery isn't acceptable or an injection isn't acceptable. But what we found from the qualitative study is that patients actually found, we did a couple of qualitative studies alongside the trial, and patients consistently reported that it was acceptable, they understood the reasons for pain, and they quite liked the idea that they could just get on with it themselves. So, you know, we don't fully understand. For some patients, the pain might not have been acceptable, or what we actually got some steer from, that the simplicity of the intervention wasn't enough for some patients. But what was very apparent, and I touched on this in the talk, that the issue of pain provocation and the simplicity actually seemed to be more of an issue for the physiotherapists delivering the intervention than the patients. For some, it was a real challenge to their clinical reasoning. They found it quite hard. So maybe one caveat to add is, if you like the idea of this intervention, you need to buy into it yourself. If you don't, then you probably won't confer very good outcomes. Thank you.
Thank you.
Okay, I think we'll stop there. We all know that when you have to give a long answer like that, it's because it's not very clear. So I think we can discuss that further afterwards. Please give questions to Chris afterwards and give him a hand.